So welcome everybody. I'm so glad you've joined us, both here in person and online for today's Dean's Lecture. My name is Catherine Clegg-Smith, and I'm the Vice Dean for Faculty here at the Bloomberg School. Dean Ellen McKenzie can't be here in person today, but she is joining us on Zoom, and we've seen her. And Ellen has would like to say a few words before I officially introduce our speaker. So Ellen, over to you.
Great. So thanks, Kate. I am so sorry I can't be with you here in person today, but I just had to zoom in and express my great appreciation for David and all he does for both the school, but also for the public's health. Now, David will focus his remarks today on the amazing and impactful work he is doing to tackle tuberculosis, which I know is his passion. But as Kate will describe in a minute, he does so much more, and we both wonder when he ever sleeps. But David, before handing it over to Kate for a proper introduction, I just want to thank you for your unending dedication and inspiring leadership overall, but specifically for the academic programs here at the school. You contribute so much, and you are always so thoughtful and caring in everything you do. Simply put, you rock. So I'm looking forward to your talk today. And again, congratulations. And Kate, I'll turn it back to you.
Thanks so much, Ellen. It's my honor to be here on your behalf and to officially welcome all of you and to introduce David. So just to share that the Dean's Lecture Series offers an opportunity to showcase the work of our newly appointed or promoted professors, as well as our senior scientists in the school, and to hear how they're changing the world through the power of public health. Today, we have a wonderful opportunity to hear from David Dowdy, who is, of course, a long-term faculty member and the Executive Vice Dean for Academic Affairs. David is also a proud alum, having graduated from both the Bloomberg School as well as the Johns Hopkins School of Medicine. And as his colleagues and students will tell you, David is the ultimate professional and multitasker, and he shines in all of the roles that he plays. As TB expert, as epi researcher, as teacher, as school administrator, and perhaps the one I'm happiest about, as a baker. Yes, because in his spare time, David is known for making some truly amazing cookies, and lucky for us, including me, who has Dean's meetings on Thursday mornings with David, I'm always very excited to see when David is sitting with a box of cookies next to him in those early morning meetings. So the cookies may be a sweet footnote to many of David's many accomplishments, but they're really so indicative of how much he cares for everyone around him and how his natural enthusiasm shines through in all that he does. David is known for being a thoughtful, dedicated, and conscientious leader with a strong commitment to our academic programs. He's incredibly thorough in all his work. If you email with him, David, with a quick question, you're likely to get back a multi-paragraph reply. And it's actually a multi-paragraph reply that you're pleased to get because it's all relevant and helpful. David brings his energy all day, every day, and he's willing to embrace even the most arduous of tasks. And a recent standout example of this is how David led us through our latest CEPH accreditation process, which is a daunting task that takes place every 7 years, and it requires countless hours by hundreds of people. And I know David will say it's a team effort, but David was there absolutely as a key part of that team in order to produce a massive self-study document and to prepare us all for a successful site visit. And David did this without complaint and with incredible generosity and skill. He not only led us to that successful outcome, but he also used this process as a catalyst to help us strengthen some of our systems here at the school. And we'll be seeing that and the fruits of that in the years to come. And he did all of this while staying on top of his vibrant research portfolio and his many other duties and passions. So as Dean McKenzie indicated, I, and perhaps she, was also hoping that David's lecture might touch on how he manages to do all of this work, but I believe instead it's going to be focused on his impressive public health work. So David today will be speaking to us on a topic so near and dear to his heart, and that's how we translate research into health in the field of tuberculosis. As an infectious disease epidemiologist and a general internist, David is a renowned expert on the epidemiology of TB, particularly in sub-Saharan Africa. His research is deeply interdisciplinary, combining experimental and observational epidemiology with infectious disease modeling, as well as health economics and implementation science. David has never been content to leave his research in the lab or his findings in a journal. He's passionately focused on how to best use discoveries to bring real change to communities. He's working tirelessly to answer questions that are relevant to both patients and policymakers, helping us to better understand case findings and diagnosis, looking at the cost effectiveness of improving health systems, and so much more. This is urgent and necessary work. Every year, 10 million people fall ill with TB, and 1.5 million people will die from it. It's the leading cause of infectious disease worldwide, but it's also preventable and curable. Solutions are very much within our reach if we put our knowledge and resources to work. And we're so very fortunate to have someone as brilliant and as dedicated as David working on this problem and doing it right here at the Bloomberg School, working so hard to train the next generation of public health leaders to do the same. So David, on behalf of Dean McKenzie and from all of us, I want to thank you for all that you do. And I'm so excited that we get to hear from you today. So please come up here and take the podium. Thank you.
Wow. Thanks, Kate. I feel like it's worth it to give these lectures just to get that kind of introduction. And they didn't even ask me to draft that or anything. That was completely them. But it's interesting that this was brought up because there were two things I was going to say as I started off. First of all, I had a flash this morning. I woke up and I was like, I forgot to bake the cookies. There was supposed to be actually a stash of cookies right here, but I just got back from vacation a day and a half ago, and it didn't click. And then the second was to say I really appreciate you all being here in the room. If for no other reason that you can't email me for an hour. There's been a lot of email back and forth, but I do appreciate that too. So I'm going to talk today about lessons in humility from M. tuberculosis, and I'm going to talk about a subject that maybe does not get highlighted in these talks that often, and that subject is failure. So I wanted to start with this quote from Bill Gates. It's fine to celebrate success, but it's more important to heed the lessons of failure. And I want to come to you today as, in some ways, a case study in failure, and to think about how we can heed those lessons. And I'm going to start by talking about our broader failure in the fight against TB, and then a little bit more on a personal level. So there we go. We'll do that. So this is what I call a portrait of failure. So the top line here is the global incidence of tuberculosis, which is the leading cause of infectious mortality worldwide. And as Kate mentioned, it's preventable, it's curable. And despite having medicines that cure TB, and despite what should be a very high public health priority, we are basically at a flat line and have been for decades. The incidence of TB is really no different than it was 20 years ago. And even as we've seen declines in HIV, for example, TB is still kind of where it was. And so I think that any discussion of what we're doing in this space against TB has to start with the fact that we're failing. But this is all happening in the context of what many people would trumpet as successes. And hopefully none of you guys are going to take this out of the room and talk to my program official at the NIH, talk to those journal editors who are reviewing some of our papers. But I think that within this room, it's worth saying this is a failure. But this has all happened in the context. So since and it was interesting to hear that this is about newly appointed and promoted faculty. It just shows what new appointments mean at this institution. But when I was, since I was an associate professor, we have scaled up rapid molecular diagnosis. So this is PCR-based diagnosis of TB from less than 5% to more than 50% of all people newly diagnosed with TB. If you had said to me in 2015, we would accomplish this, I would say, wow, what a success. Since that time, we've developed new drug regimens that can treat drug-resistant TB now with 6 months of oral therapy. So in 2015, if you developed multi-drug resistant TB, this is what you're going to have to take every day for 18 to 24 months, maybe the injection only for nine months, right? But imagine getting a shot every day for 9 months and then having to take this many pills. So the number of pills to treat someone with drug-resistant TB was equivalent to the height of the Golden Gate Bridge, right? So that's how much we had to put into someone's body to try and get rid of this. Now, this is all you have to do, and you can do it with 6 months. As much as you'll hear about how drug-resistant TB is this major problem and challenge, we're actually making progress. So the proportion, the fraction of people with TB that have drug resistance is going down over time, right? If you had told me this in 2015, I'd say, wow, what a success. We have a pipeline of TB vaccines. So thanks to lots of R&D effort, we have one that had 50% efficacy in a phase 2b trial, which doesn't sound great, but in the world of TB, this is actually quite a breakthrough. We have 6 candidates now in phase 3 trials. Again, had you said this to me in 2015, I'd say, wow, what an incredibly successful 9 years we've had. The number of people getting preventive treatment for TB. So this is prevention that can lower your risk of getting TB by 2/3 or more, has quadrupled during this time. And even more heartwarming to me is that it's not just about people with HIV, so here in the yellow, but now we're starting to get to household contacts and other people who need TB prevention as well. Again, what a success. And yet, we haven't budged this needle, right? And so while we in our kind of scientific towers have developed all of these new exciting innovations, biomedical innovations, diagnosis, treatment, prevention, etc., we're not succeeding when it comes to reducing the burden of this disease. So that's the kind of the big picture of TB as a whole, but I want to make this a little bit more personal. And so I went back as I was preparing for this lecture and thought, what is it that I've done during this time, since 2015? And it became pretty clear pretty fast that one of the things that I've done is failed a lot. And I think that this is a piece in the Harvard Business Review from a few years ago. Increase your return on failure. And you guys can't read all this summary at the bottom, but what it says is, although many companies claim to embrace failure as an integral part of the innovation process, near zero tolerance for it blocks them from pursuing new ideas. And what this and others go on to say and suggest is that the reason that we don't fail is, first of all, we don't tolerate it in our own institutions, right? I can't go to the NIH and say, hey, look, I failed at my first 5 R01s, please give me a 6th, all right? We have to put together these long, lengthy CVs to say what a success I am, right? But also, we don't systematically go back and think about, well, among the things that we failed at, what are the lessons that we can learn? And so that's what I wanted to do for this lecture is to go back and think through my own failures. What are the lessons that I've learned? And as I was doing this again, I recognized that in the context of a lecture like this, there's only going to be like one take-home message that people are going to leave with, right? I can't give you 10 different failures and 10 different lessons. So I was like, if I put all these failures together, is there some sort of theme? And the answer was very quickly yes. And so what I'll do is walk you through 5 of my own failures. And you'll quickly see the lessons from those failures emerge with a common theme. So the first failure is a trial called the mHealth trial. So this was a randomized trial of contact investigation for tuberculosis. And what I'm going to do with each of these is I'm going to just briefly, I'm not going to go through lots of detail, but I'm going to tell you what the failure was and then the lesson. So the first one, the first lesson is to listen to communities. So this was a household randomized trial of home-based contact investigation in Uganda. And what we did here was relative to the standard of care, which is to go out to the household, say, if you've got symptoms for TB, come back to the clinic and we'll diagnose and treat you. Instead, we came out to them and we said, we will collect your sputum for you. We will send you an automated text. You don't have to leave your home unless you have TB. And what happened in the context of this 5-year R01 funded trial is that there are only 12 people newly diagnosed with confirmed TB. And this was out of 900 household contacts randomized, which was not anywhere near the sample size that was desired. There was no difference between the standard of care and the intervention. And ultimately, clearly, this well thought out, well conceived intervention had no impact in the context of the trial. And so what happened? So first of all, out of all the people who could participate, only half of them consented. And then of those, only 40% submitted a sputum specimen. And so off the bat, we're already down to 20% of our possible sample. What happened, I went out and did a site visit here 2 years into this trial. And I talked to the people who are working there, and they were like, oh yeah, everyone just gives us fake numbers. We can't call them and give them their results back because they're and I was like, well, do you try to fix this? And they're like, no. And the whole idea is that without establishing some sort of rapport between the people who are doing the intervention and the people who are supposed to be receiving the intervention, the clients had no incentive to actually give a real number, and the workers had no incentive to try and get that. When they went out to the households, there was stigma around providing sputum, etc. And the intervention itself was just not successful. So less than 20% of the text messages were actually sent, delivered, read, understood, because people borrowed phones, people weren't literate, people didn't know what to do with these text messages. And a tremendous investment in this software of hundreds of thousands of dollars, right, ultimately landed with 12 people getting diagnosed. And the lesson here is, before you try and improve the outcomes of the community, listen to the community first and make sure that what you're doing is something that's actually going to work for them. Going on and not necessarily learning some of these lessons, so we'll go to the next chapter in failure, which was it's called the 3HP options trial. And here the lesson was not necessarily listen to communities, but listen to the clients as well. So this was a pragmatic, randomized trial of 3 strategies for TB preventive therapy among people with HIV in Uganda. It compared directly observed therapy, which is the old way of doing things, watch people as they take their pills each time, versus self-administered therapy, which is more empowering, but sometimes people don't do what they're supposed to do. And then also an informed choice. So sit down and say, well, here are the benefits of directly observed therapy. Here are the benefits of self-administered therapy. You choose. But the key here is that both of these strategies were facilitated by certain things that we don't necessarily do in practice. So we provide transport reimbursement. So we pay for you to come to the clinic. We redesign the clinic so that you can get through faster, and we send these automated reminders. And the transport reimbursement is particularly interesting because what we found, of course, is that the people who live close to the clinic wanted to do directly observed therapy because you get the same transport reimbursement, but you don't have to pay as much for your transport. So you're making money out of the deal, right? Whereas the people far away wanted self-administered. But we found high completion in all these arms, more than 90%, no difference. You could call this a success. And in our journal article, of course, we did. We said in all of these arms, we achieved more than 90% completion. But this is something that is never going to get taken up in Uganda and is never going to lead to improved health outcomes, at least in its current form. Partially the reason is that the cost of doing this is $90 to $140, and this is you can put someone on antiretroviral therapy for a full year for this cost, and so it's very unlikely that we're actually going to be doing these sorts of things. And so what were the reasons for failure here is that barriers to treatment are expensive to overcome. The things that keep people from taking the treatment that we think they need are not cheap. And if you get what you pay for. If you try to do this on the cheap, you get poor outcomes. If you pay for it, you get great outcomes, but then that's money that you can't spend elsewhere. For a client to come for a single dose of preventive therapy was over $5 when we asked. And that, in this particular setting, is 39% of their median weekly income. And so this would be like asking someone here in the States to pay $350 out of pocket for a doctor's visit, right? And you can imagine if you had to do 12 visits every week for someone you didn't even feel sick, right? How many people are going to do this, right? And you think, of course, well, no, but yet we think that this is going to happen in other places, And I think we as a TB community probably overvalue preventive treatment as a whole. We're talking about very expensive drugs, very expensive interventions, and we're trying to get that piece of prevention in because we want to do everything we can against TB, but this is an expensive piece. And so I think we need to listen to our clients here that if interventions are not priorities to them, if they don't feel like this is something that they need, we should only be prioritizing it ourselves if it's a large benefit or we can do it cheaply, And so again, we can trumpet our success. We can say, well, we achieved 93 to 95% treatment success, but we did it in a way that's not feasible to actually implement. And so again, we need to be listening to clients. We need to be listening to communities. On to failure 3. So Predict TB was another trial that we recently completed. And here the message is to listen to providers. What this was is a trial of a very simple risk score. So we asked these 10 questions: sex, age, HIV status, diabetes, symptom duration, and the number of TB symptoms. Based on that, we can assign a probability, and we can say if you score really high, maybe your risk of TB is so high that you should get started on treatment. Because in these clinics where we were working, we didn't have access to same-day molecular diagnosis. So you have to take a sputum test, send it off to the lab, and by the time that comes back, you've lost 15% of your patients. And so the idea is if you can get people started on treatment right now, today, that maybe they'll be more engaged in the system. And so what happened here is that we put together this effectiveness implementation evaluation. So we matched pairs. We had 4 clinics that were doing this intervention, 4 clinics that were not. And what we found was that there was no difference, again, in same-day treatment of people with confirmed TB. And one of the reasons for this was that when you looked across clinics, the implementation was quite variable. So this dark line, or this dark bar, is the number of people who are symptomatic. The next gray bar is the number who used the score. The next gray line is those who scored high enough to warrant same-day treatment. And then this is the number who actually got the treatment. And so you can see there were some clinics like this one right here where almost everyone who had symptoms had the score, and almost everyone who had the score above the threshold got treated. But then you had others like, say, this one here, where almost nobody even had the score used, and among those who scored high, very few of them got started on treatment. And so it was highly variable implementation. And what we found was when we talked to the providers about this, they loved the score. They were like, this is easy. We don't need to use a computer. We can calculate it. And we even timed how long it took to calculate it. And they said it was 2 minutes, 2.08, I think. But even when they had this score, first of all, some people were coming in and looked so well that they're like, we don't even want to do this in the first place because we know that you're fine. We're not going to treat you for TB no matter how high your score is. Others were like, okay, this is helpful for me, but I still want to send my results out and wait to get those results back before I start someone on treatment. And part of the reason for this is that I have to, for every person who has TB, I have to put them down in a register. And if I register them as having TB and then 2 or 3 weeks later get a negative result and have to take them off the register, it makes them look like I was losing them to follow-up. And it's going to come back on me. And I don't want to have those X's on my chart, right? And so I'd rather wait, even if I think it might be better for the patient to start them on treatment. I'd rather wait so that I make sure that I'm only going to be starting them on treatment if I know I'm going to be completing the full course. And also what happened was, during this whole study, the molecular diagnosis was being rolled out, and so we had to when a clinic got these devices, we had to flip it out and bring a new one on. And the new clinics that came in didn't have the same level of buy-in. They didn't use the score in the same way. And so what happened is we had this tool. We thought that it was something that was usable. And indeed it was usable, but the way we thought it should be used, which was to get people on treatment immediately so that you didn't lose them to follow-up, was not the way that it was actually being used in practice, right? And so how it was being used in practice was to help with the decision-making process, maybe get people more engaged and help the providers feel like they had more confidence in their decision. But that's not what we're measuring. And so at the end of the day, if you look at our primary outcomes again, no difference. All right, so we're 0 for 3. Let's move on to 4. So this is a trial called the DOT. DOT is for digital adherence technology. And what this is, or the particular digital adherence technology that's being implemented here, and it's not all that digital, is to have these are medication blister packs, and when you punch out your medicines, some of them will reveal a number for you to text, and so you then text that number to say, I took my medicine for the day. And so it's a way of observing the medication being taken without actually watching someone take the pills. Of course, someone can punch their pills out, not actually take the medicines, and still text the message in. We don't know, but the lesson here is to listen to leadership. This was a pragmatic step wedge trial of this technology. We took 18 health facilities over 8 months, scaled them or kind of phased them into using this technology. And there was an intention to treat analysis and a per protocol analysis. And in the intention to treat, there was no difference. So meaning if you took the entire population of people who could have had this intervention and the entire population who did not, there was no difference actually in treatment success. But in the per protocol analysis, so among those people who actually started on this technology, there was a difference, meaning that among those who did not, there was a negative difference. And so we might have just been selecting for those people who were likely to adhere in the trial design itself. But half of all people who are eligible for this were never enrolled. And the cost of this, again, was quite high, so $350 per treatment success. Despite this, the National TB Program was very excited and very involved in this. So they were co-authors in this trial, and they said, this is something that we really are excited about because we really need to prioritize treatment success, and we really are needing these sorts of interventions. So they were totally excited about it. But when they went to the people above them, the Minister of Health, Minister of Health said, absolutely not, right? Way too expensive. This is way outside of our budget. And when this was implemented in other settings, the evidence for actual improvement of population health outcomes was not all that compelling. There's been a meta-analysis of this particular intervention, and the conclusion is there's no compelling evidence that it improves outcomes in terms of treatment success. And so you have a very excited national TB program, but a very lukewarm Ministry of Health, a divided scientific community, and even within our community of scientists in performing this trial, I think there was disagreement as to whether or not this was something that should be implemented. And ultimately, again, failure. The reason for failure is that there's this disconnect, right? So you can't, I don't think, get political consensus from the National TB Program and the Minister of Health and the scientific community up front, right? But without some sort of attempt at building that consensus, when there are results that are difficult to interpret. So this works well for the people who use it, but doesn't work well in a population. So it's a hard message to get out. And as I think we've seen in our own politics, right? Simple, hard-hitting messages are what people sometimes need. So I think, again, the failure was due to a lack of listening, right? And not listening to the people who would be responsible for funding this, to the scientific community who would be responsible for saying that this is something that we should be doing more broadly, and even to our own internal collaborators. As if that was not enough failure for one lecture. We'll move to number 5, and I hate that Colleen's here because she was leading this, but this was actually my the first R01 study that I was the PI of, Keratote TB, and here I'm going to argue that the lesson was to listen to team members. So this trial was, and I'm going to focus on half of it, was a cluster randomized crossover trial of TB contact investigation. So we compared a household-based, the kind of the standard of care, you go out to do contact investigation in households the way I talked about with the very first of these, versus an incentive-based design where we gave people coupons and said, go and find the people you think might have TB, bring them in. If they come and show up, you get a financial incentive and they get a financial incentive too. And once again, what happened over a 5-year R01 funded trial was that we found 17 secondary cases of TB in the household-based arm and 17 in the incentive-based arm. So not only a very small number, but exactly the same number. What? Was it significant? Great question, and no. and so again, what happened was we lost people at each step of the cascade. So, only 2/3 of the households that were eligible got visited. Only half of the contacts in those households were enrolled, and only about half of those provided sputum. And again, I would argue that this incentive-based contact investigation, despite the fact that we trumpeted it in our publications and used it to successfully get another grant on top of this, right, is very unlikely to be implemented. And I think that part of the reasons here was that it was very difficult for our team members to engage. So one of our sites, or most of these sites, were in a rural setting where we had this small number of team trying to cover 28 different health facilities. They were running around all the time, more turnover, and it's really hard in a trial to replicate how this would be done in a programmatic setting. And so at the end of the day, less than 20% of people who we should have been, evaluating, we actually got sputum specimens from. And had we, in retrospect, had we thought to kind of talk to our team members, hear from their perspective what this was like, we might have said, wow, this is really not something that's going to work. And again, I think just kind of highlighting the distinction between the significant sections that we write in our grants, the conclusions we write in our publications, and the realities of actually getting out and improving health outcomes in the end. So, if it's not clear by now what the summary is, right? The summary is listen more. This is a quote from Yogi Berra. I don't know how many of you are baseball fans. Last night was the All-Star game. Some of you who really follow baseball may know that the starting pitcher for the National League is a rookie pitcher, right? And he's phenomenal, right? But I don't know I tried to figure out exactly what Yogi Berra was referring to when he said this, and I don't know, but I'm going to make it up, right? So in baseball terms, a heat, right, is how fast you can pitch, right? And it's not the heat, it's not how fast you pitch that determines your greatness as a pitcher. It's the humility, right? And so what's going to determine whether this particular pitcher, I think, goes on to become one of the all-time greats, or someone that we forget after a year or two, is whether he has the humility to recognize that there's always more to learn, right? That we need to be listening to those around us, and that the moment that we stop listening, the moment that we stop being willing to adapt and trying to change, is the moment that we lose our own footing. So yeah, I think the message is to listen more, and I hope that I am slowly learning this message myself. We will see. This is where I kind of am going to go a little bit off script, and we'll see how well I can get through this section. But acknowledging also Judy to say that Judy's response is she offered to look at this because she and I have been exchanging quite a few emails these days. Those of you who are laughing know why. And she said, it shouldn't just all be about failure. It should be about, and I think the part of the message here is that actually failure and success are intertwined. That we can't have failure without success, but we also can't have success without failure. Nor do I think we can have success on our own. Anything that I would count as a success in my own life has been through learning from others and interacting with them. But part of the success of all of these studies is the people, right? So here are our various teams Unfortunately, Karatoti was the one that I didn't have a photo of. I should have found Colleen beforehand, but so this is our Predict TB team. This is the options team. This is our Chase TB team that I didn't talk about, but this is the broader team in Uganda. And these are all of and this is the M Health trial team. These are people who, throughout this process, I think, hopefully learned and grew themselves, but certainly taught me, and hopefully taught me to listen a little more. The Center for TB Research is this kind of vibrant setting of research where, and I think has continued to thrive because of the people. I could put a slide up here with 1,000 names of all the people, and I don't want to do this and have everyone looking to see if their name is up there or not, because I know I would miss many. And so but I did want to put the 8 either K awardees or soon to be awardees, also by way of saying these are kind of components of success, that in our journeys as we go along, we may fail again and again and again in science, or we may succeed at science but fail to implement in public health. But I think that the most reliable success is always the people. Also, not here, but part of what has happened since 2015 for me are lots of other things. Like work does not happen in a vacuum, right? And so and these other life lessons also, I think, are both lessons in failure and lessons in success. Since 2015, there have been in my life, without going into too many details, but 1 wedding and 2 divorces, and maybe an early light beyond that. Illnesses in family members who I felt like should be well when I was sick, not the other way around. My dad, if there's anyone in this world who I would say is my hero, right? Beginning and ending his fight with cancer. I don't like the idea of losing one's battle with cancer, because I think he won. But again, all of these can be seen as failures. They can be seen as successes. Thinking about marriage, for example, that sometimes the crowning success of a marriage is to know when to let it go and to do it well. And so thinking in all of these things, that failure and success are 2 sides of the same coin. But if there is a measure of success, it's people. And I think this is also a time to thank all of you. That it means more than to see you in the room, on the Zoom room, to think that this institution. Ellen said she wanted me to talk about the leadership stuff, and I'm not going to, but I will say, as far as this institution, right? What makes this institution so great is not that we have #1 plastered on the U.S. news, right? It's what causes that, what creates the foundation for that, which is all of you, right? And the fact that we are in this together, working towards this common mission, and even if that mission is marked in some cases by many more failures than successes, those failures represent not only an opportunity to learn, but also successes in their own right. And so I think with that, the words I'm going to leave you with are listen more. And I hope to listen more to each of you in the days, weeks, months, years to come. So thanks. So in the spirit of listening, I'd love to listen to questions people have. Those of you who are on Zoom, if you want to raise your hands, you are. I think we can call on you, or those in the room. I think we need to get a microphone so that the people on Zoom can hear you. Wow, that was a lot. But Colleen, I saw yours first, so.
Thank you so much, David. I'm sitting here next to a potential next generation TB researcher. Yeah, thank you. And something that I just want to add, which David alluded to at the end, but really didn't get mentioned that much, is David's tremendous success as a mentor, whether it's to master's students, PhD students, postdocs, staff members, junior faculty, beyond junior faculty. David has really, his whole career here at Hopkins has been characterized by his excellence as a mentor. So thank you on my behalf and all of those that you've brought with you along the way. So as a partner with you, let's call these null findings, maybe. I guess my question is, like, philosophically, you alluded to this. We saw, for example, the huge rollout of new diagnostics for TB. We thought these were home runs. We thought these were like game changer, can't miss. We're going to bend the curve down, and they weren't. And you and I have collaborated on a couple things where the conclusion was, okay, we didn't do better than what we're already doing with this new intervention, but here's another option that works just as well. So I guess my question for you is, like, in TB and other, diseases or concerns in public health, should we be like swinging for the fences, to continue your baseball analogy? Should we be swinging for the fences more and trying to hit these home runs, or should we like dinking out these singles like we've been doing, that are like expanding the options that we have, and maybe they're not earth shattering. I think you've done very well publication wise with things that you're calling failures or null findings, but yeah, what do you think philosophically we should be going for?
Yeah, no, great. Thanks, Colleen. And I think the answer to your question is yes. I mean, I think that I would hate to see us stop swinging for the fences, because sometimes you never know when you're going to hit that home run. But at the same time, you have to keep hitting the small things too. And I think that this is, if we're going to keep this baseball analogy going, right? I mean, the teams that do the best are the ones that can do both, right? So that have the power in their lineups, but also stick to the fundamentals and keep getting those few extra runs that they can win by one at a time. And I think that what's not shown in some of this, and kind of intentionally so because of the message, but even though there's it looks kind of flat, there's a lot under here that has actually been successful. Mortality as a whole is going down, but within certain areas, within certain communities, we've seen dramatic declines. And I think if we keep only looking at the big picture, high level, and don't recognize all of these smaller successes, that's another sort of failure. That I think we should be acknowledging those and thinking about how we can grow. So I think both. I think we need to keep up the quest for innovation and these big home runs, but also the desire to make a difference one community at a time. Yeah.
David, you hand up online, maybe to go to next.
All right. Okay, we'll do Asta, and then Bill, I see you're next. We'll get to you, I'm sure.
Thank you so very much, David. That was a wonderful presentation. And when I was working in Nepal and Tanzania, there was a very large interconnection between TB and HIV. And one of the things that I realized when I was working there was this issue of like the social determinants of health and stigma, and addressing those as a way to both prevent as well as understand this this course of disease, you know. So I had a couple of questions surrounding that. One was, can you give your thoughts on how it is the social determinants of health can be addressed through these multiple clinical trials that you just presented on? Another thing that I was also wondering is, one of the things that we've been realizing more and more is participatory methodology and involving the people that where we want to bring that sustainable change within the research process, and the capacity to do that when you are conducting the clinical trials. And then lastly, one of the other things that I wanted to get your thoughts on is task shifting and the use of community health workers and other catered health workers in order to prevent as well as address TB morbidity as well as mortality.
All right, great. So lots of questions, and I'm going to keep this relatively short. But I will say, like, definitely send me. You can send me an email. I won't mind, and I'll be happy to follow up. I do think that, you know, TB is one of these examples where, and I think this is true of many of our health conditions, that really to make a difference, we're not going to see that without tackling some of these social determinants. But these social determinants are also very deeply ingrained and very challenging to address. So in addition to going for the big innovations and the small innovations, I think we also have to be chipping away at those social determinants that underlie TB and many other diseases. And I think that some of the things that you've described, task shifting, et cetera, are ways to potentially do that. But I will, rather than giving a prolonged answer, I'll say I'll be happy to follow up. But I think a great point. So.
David, thank you very much. And I just want to acknowledge it takes a lot of courage to stand up in front of a group like this and talk about your failures, both in the field and personal. And I hope that you'll help open up a space for all of us to acknowledge our failures and talk about them and learn lessons from them. So thank you for that. My question is, what advice would you give an early career public health researcher on how to operationalize listening more?
So great question, but it's almost like you read my mind of things that I was thinking I might try to say in this lecture and didn't get to. But one of the things that the one thing I would say to any early career investigator is find people that you work well with, meaning that they are effective at what they do, have the same kind of work style as you, that you enjoy working with, and that they are listeners themselves. You know, I think that we all learn from the people around us, and if we surround ourselves with other people who do a good job of listening, we do more of that ourselves too. And I think that, you know, part of the reason many of these things are all from the same kind of group in Uganda is I was a medical intern and resident at a place where there were 2 pulmonary fellows and 1 collaborator they had in Uganda, but they all fit that profile of people who are effective at what they do, had the same kind of work style as me, but also listen themselves. And I think that, you know, once you find that, and it's hard to find, and it's random. You know, like it's not that I knew to like position myself there. I just happened to come upon those people. But when you find those people, like ride that horse as much as you can, right? Because it will, it may lead to a lot of failure, but it will also kind of, I think, lead to success. So, great question. Homie, you're fast, and then is there?
There's some more questions online. You probably have time for maybe 2 more questions. So.
2 more, okay. Well, Homie, you got your hand up fast, so I'll
I was wondering, the impression that you gave to us today about failure reminds me of what Winston Churchill once said. He said, going from one failure to the next without losing your enthusiasm is a success. So I'm debating whether I should like failure more than success in order to reach the success ultimately.
Oh, good point. I appreciate that too. Did you want to?
There's actually 2 questions online from 2 different people. Dr. Richard Palmer, would you like to unmute yourself? Or I can read the question. Yeah, I'll just read it. He has 2 questions. He said, please bear with me if my ancient and partial knowledge is revealed. I've given that the genetic sequence of the tuberculosis has probably been accomplished. Hold on, I need a second hand here.
There's so many accolades, it's hard to find them.
Yes. Has probably been accomplished. Are there creative RNA vaccines being considered or developed? Vaccination early in life might provide long-time protection. And then the second is, among the comorbid HIV TB patient, has epidemiology revealed whether the pattern is that the HIV and has immunosuppressed the host so that the TB is reactivated, childhood, early infection, or new opportunistic TB infection?
All right. So quickly, we have sequenced the TB genome. There are a lot of vaccines that are being developed. RNA is, I'm sure, somewhere in that pipeline, but I don't think that the most promising vaccines are RNA vaccines right now. HIV, we know HIV causes immunosuppression that increases the risk of TB. But in fact, I mean, this is, I'm right on the slide here that, you know, if there's been a place where we've had success in TB, it's been among people with HIV, because we've done a much better job of treating HIV. So it is, I mean, HIV and TB are still, you know, close siblings, but if anything, we've done better in navigating the HIV TB landscape than we have the rest of the TB landscape. I can stay, but I mean, yeah, I don't know.
More online, but do we want to?
We've got one here. Yeah.
Okay. Thank you, Professor, for such an amazing presentation earlier. I'm Fiona, and I also have already in the TB project officer in Indonesia, to be precise, in the correctional facility for 4 years. And I have 2 basic questions, actually. The first one is, when you did a screening on a certain household, which family members that were targeted to be tested? For example, if there is a family member which tested the positive, and there was another guest that visited their house at that time, did he also get tested? And how can you track the contact investigation of that guest? And the second one is, with so much loss to follow-up participants, what's your advice to the policymaker, in this case, which was the Department of Health, in doing frequent mass screening and controlling the TB spreading, not only to make it effective but also to make it cost efficient? Because these 2 problems are my big concerns since I have already in that TB, TB preventive and promoting actions for 4 years. Okay. May I add another question, please? Oh, okay, thank you.
Yeah. I'm going to say this is another one where you should email me, and I'll give you a longer response. But in general, we do have to come up with definitions of who is in the household, and there will be definitions in different studies. Sometimes we will include the guests, and sometimes we won't. And as far as to follow up and cost, I mean, these are both kind of ongoing challenges of TB. Is that TB is an expensive disease to find, right? So the diagnosis and screening is very expensive, and so it's hard to do that when you don't have the kind of rapid, cheap tests that we have for HIV, for example. But I'll give you a longer response if you email me. Yeah.
Okay, and then our final question, I think, will be online.
And I'll just read it. It's from Namasha Fernando. Thank you for your incredible presentation, Dr. Dowdy. Understanding the importance of failure and learning, what recommendations do you have for teams and institutions seeking to create safe spaces for failure?
Oh, so that's a great question. Thanks, Namasha. Namasha is one of our Writing Center tutors, so we're very excited for this. But, I think that part of this is to allow for part of this is just culture, right? And so the example that comes to mind is just 2 days ago, as I was coming back from my vacation, I was on an airplane. We ended up sitting on the tarmac for 2 hours because they had some electrical problem that all ended up being nothing at the end of the day, right? But the culture of the airline industry is one of such safety focus that they don't care if they're going to take 180 or however many people are on that plane and make you sit on that tarmac in no air conditioning for 2 hours for just to get through their checklist and run through their engine one more time to make sure that it's actually functioning, even though 99.9% of the time that engine is going to be functioning. They just don't care. And I think it's the same sort of thing, creating a space where failure is okay and actually promoted. And we don't care if that means that there are adverse consequences, that we're going to prioritize this, and we're going to say the only way we're going to have success is to allow for failure, right? And so we could get into long discussions about what this would mean for promotions processes, how we should revise our publication processes, how we should even rethink academia as a whole, right? I will not do that, I think, because we have a reception or something to go to afterwards. But I think thinking of that, I mean, that the airline industry has said safety is key. And if we can say failure is key to the academic process, and then take that as our North Star and think about how we can then redesign our processes accordingly. And it'll take many, many years, just like it took many, many years to get to the point where they'll do that on the airplanes. 30 years ago, they would have taken off and 1 out of 200 would fall out of the sky, right? But over time, if we prioritize that, I think we can hopefully do a better job ourselves.
I don't think that's right.
1 out of 200. Well, thank you so much, David, for a wonderful talk. I feel very, very lucky that I get to work with you in one of those one of those people that you find people that you like, that listens, that pushes you to do better. So I feel I'm really, really lucky in that regard. So I just want to, on behalf of all of us, once again, thank you for a great presentation, a really insightful and humble and personal presentation. Thank you. So.